Hello, my name is Jane Chiodini. My background is actually in primary care. I became a practice nurse in 1990 but went on to specialise in travel medicine by undertaking a master's degree at the University of Glasgow in the mid-90s, and I graduated in 1998. Since then I've been busy writing and teaching on travel, and I run my own training business. I was chair of the Royal College of Nursing Travel Health Forum from 2000 to 2006, and I'm currently the Secretary of the Faculty of Travel Medicine of the Royal College of Physicians and Surgeons of Glasgow. However, I still work part-time in general practice, where I run a dedicated travel clinic in my surgery in Bedfordshire. Today, travellers take far more exotic and adventurous holidays than ever before. The range of vaccines available and disease prevalence has changed significantly over the last 2 decades, and travel health has become a very complex field of practice. The core practice is both travel risk assessment and travel risk management, not only of infectious diseases, but also conditions resulting from the natural environment, such as extreme temperatures or high altitude, local circumstances, such as road traffic accidents or personal safety and security, and the impact of travel on any underlying pre-existing medical condition. Advice should be given on all these topics when appropriate. Important bodies such as the Royal College of Nursing, the National Travel Health Network and Centre, commonly known as NATHNAC, and Health Protection Scotland's database TRAVACS all stress the importance of undertaking a thorough risk assessment within the travel consultation. This will involve the collection of information both about the traveller and about their itinerary. Useful travel risk assessment template forms have been designed. For example, there is one in the RCN publication Travel Health Nursing, Career and Competence Development, and one in the NATHNAC important publication Health Information for Overseas Travel, commonly known as the Yellow Book. It's important that surgeries obtain copies of these publications. Following the travel risk assessment process, the nurse can then decide the actions to be taken to protect the health and well-being of the international traveller. This will include identification of travel vaccines recommended and the appropriate travel health advice required. If travelling to a tropical malarious area, advice will also be needed on malaria prevention measures and discussion and selection of the correct malaria chemoprophylaxis for the trip. For vaccination, the nurse first needs to identify that the childhood immunisation programme is also up to date, what travel vaccines may have already been administered in the past, and provide the traveller with sufficient information about the travel vaccines to obtain informed consent. Administration of the vaccines and recording of all drug data on the computer system and recording of the travel risk management plan is essential for best practice. Clearly, there is a significant amount of work to do in a travel consultation, and the RCN document states that it would be unsafe to allow only 10 minutes for a new travel appointment. A minimum of a 20-minute consultation appointment per person should be allowed to exercise best practice. Travellers with more complex needs, such as backpackers or individuals requiring malaria prevention advice relevant to their destination, may need a longer consultation time. In a typical 1990s travel consultation, the nurse would assess the traveller and decide which travel vaccines were required, go to the fridge, take out the vaccines and then administer them to the patient. In effect, though, the nurse was prescribing without being allowed to do so. In the year 2000, legislation was passed bringing into force the use of patient group directions known as PGDs and patient-specific directions, which we abbreviate to PSDs. These are legal documents to allow the administration of any prescription-only medicine, a POM, by a non-medical prescriber. So today, your nurses can either administer a travel vaccine either under a PGD, a PSD, or by means of a prescription if he or she is a qualified nurse prescriber. An interesting frequently asked questions document on PGDs and PSDs is available on the NATHNAC website, which explains some history on the subject. In brief, in 2000, all licensed vaccines could be given under a PGD, which was a detailed document allowing the administrator of the POM to an unidentified patient before presentation for treatment. Although the name of the traveller was probably known, it wasn't until a risk assessment was performed that a decision to administer a particular drug was identified. The PGD allowed such administration and provided a smooth consultation for all concerned, as long as the information in the PGD was followed. However, in 2007, a change occurred to stipulate that in an NHS setting, only NHS vaccines could be given by means of a PGD, and all private travel vaccines had to be administered under a PSD. A PSD is an instruction from a prescriber to a non-prescriber to administer a drug under the order, but it has to include the name of the patient, clear evidence that an assessment has been undertaken, and the name and the dose of the drug supplied. Therefore, if your travel consultation nurses are not nurse prescribers, they can only give travel vaccines if there is an up-to-date PGD in place which they have signed, or if a PSD is signed before the vaccine is given. I'm aware that many practices possibly get the PSD signed after the event, but this wouldn't be a legal process as the nurse would then technically still be prescribing when not allowed to do so. Therefore, a process needs to be developed within your practice to allow for a PSD to be signed for any vaccine given, which are either private or there is no PGD in place. In my surgery, we have a PSD built into our travel risk management form, and I would get a GP to check the details and sign it before I administer a travel vaccine to my traveller. This inevitably delays my consultations, but it's the only way I can work legally. Many PCTs write patient group directions for the NHS vaccines, however some do not. A surgery could develop their own PGDs, but they still need to have it ratified by the PCT. And in the future, it remains unclear who will be responsible for writing these documents when the PCTs no longer exist. A travel health consultation can be complex due to the time it takes to perform, coupled with the issues surrounding the legal administration of travel vaccines. However, such processes are in place for good patient care and standards of practice. Whilst patient protection is of paramount importance, it is essential that a registered nurse undertakes travel health duties in your surgery and that they abide by their professional code of the Nursing and Midwifery Council, the NMC. The competency framework for travel health nurses is explained in the RCN document and includes such statements as ensures travel health knowledge is always up to date, uses recognised online databases on a frequent and regular basis to ensure the latest national recommendations are always followed, performs a comprehensive risk assessment and knows how to carry out risk assessment effectively, insists on adequate time to perform the travel consultation and negotiates sufficient time if this has not been permitted, demonstrates evidence of learning to apply skills and knowledge in the field of travel medicine. For example, a minimum of 15 hours of relevant learning plus mentorship in clinical skills before undertaking a travel consultation alone. Reading of this document in its entirety is highly recommended and can be obtained by going to www.rcn.org.uk and searching in publications with the title Travel Health Nursing, Career and Competence Development. Recording of information is essential and strict comprehensive guidance is provided by the NMC. An NMC hearing was held in February 2012 against a nurse for many counts of misconduct. The document related to the case is available in the public domain at www.nmc-uk.org and searching on travel vaccines. Of the charges brought against her, 23 were travel related. Examples were failed to undertake or failed to record that she had undertaken a risk assessment in respect of patient travel plans, failed to consult or failed to record that she had consulted the Travac's recommended schedule of vaccination, failed to advise patients and or failed to record that she had advised patients as to the potential side effects of vaccinations administered, failed to check and or failed to record she had checked the recommended UK schedule of routine vaccinations, failed to give advice or failed to record that she had given advice about malaria prevention and or medication to patients whose travel plans included destinations for which Travax records a malaria risk in certain areas. Best practice demands such care is given to the traveller, but it is important to ensure recording of the details of the consultation also occurs. A new risk management form has been devised and is available for surgeries to consider as a template. It can be found in the RCN publication, Travel Health Nursing, Career and Competence Development, from the RCN website.